We're going to talk specifically about COVID-19 and its propagation and how it does some of the things it does. There's a great deal of granularity here that you do not need to know, but there's some things that I want to call to your attention, and there are going to be some things I point out that you do need to know, and I will call those out when we get to them. And there's also some language that when you hear this kind of language, you should start thinking about COVID-19, but not only about COVID-19. I'll call those things out as we get to them. Now, one thing I've already indicated to you is this viral spike is the key connector, literally, to basically ACE2 receptor cells that enable the virus to insert its DNA and then multiply within the host cell. That's the way that the whole thing starts. Now, those ACE receptors can manifest in multiple areas within the respiratory system. So that is why the symptoms can be so varied from, I'm having allergy symptoms to full-blown pneumonia. One of the things that COVID-19 does is it kills T lymphocytes, which are important mediators in our immunity. So we need those T lymphocytes to help combat infections such as COVID-19, and COVID-19 kills them. So that those two processes enables this increase in viral replication. So now the virus is free to multiply and produce the infection. It's also explains why there can be so many manifestations, because there are lots of cells throughout the body that have ACE2 receptor sites on them. So subsequently, the infection can spread to the pulmonary capillary endothelial cells, which are obviously abundant throughout the upper and lower airways. This then leads to this influx of monocytes, neutrophils, and inflammatory cytokines. We've touched on this a bit already, and those inflammatory processes then create multiple complications such as vasodilation, inflammation, cell death, and the list goes on up to including the manifestations, the symptoms associated with sepsis. So what then occurs is the issue here is because there are so many locations for ACE2 receptors throughout the airways. It's not like pneumonia, which tends to aggregate in one location in a lobe or in a region of the lung. Because remember, bacterial pneumonia is focal because the bacteria is in an area where it reproduces. This virus is inserting itself into cells, so it finds the receptors in various cells throughout the airways, which means multiple alveoli become affected simultaneously, not a region of the lung. So you get this diffuse damage or injury to alveoli throughout the lung fields. The more diffuse the injury, the greater the area of injury, the more severe the manifestation is going to be. And this produces on X-ray what you'll hear referred to on X-ray and both CT as a ground glass opacities, because it looks like someone's taking diamonds and ground on glass. And that is a result of all of these small areas of injury, but there being so many of them. By small areas of injury, I'm talking about the alveoli, these small little pockets all over the lung fields that are injured, not a lobe like I've illustrated earlier with such as an infusion or if pleural effusion or something like that. Also, as the pulmonary edema evolves from this injury, from the vasodilation as a result of the cytokines, you have that pulmonary edema, but also you have this hyaline membrane inside the alveoli, which is a result of all of the T cell lymphocytosis and other pulmonary endothelial cell damage that is filling up, that is mixed in with that fluid, which begins to fibrose and thicken, much like the layer on top of gravy when it sits at room temperature and cools. So you have fluid in the interstitial space, that pulmonary edema. You also have alveolar edema in addition to a hyaline membrane forming over that, which makes oxygenation and ventilation very difficult in these patients. So that's what creates such a severe illness from COVID-19. Now, this slide shows you a great deal of information about the evolution in essentially the three phases. I don't want you to memorize this slide, but I want to present this to you. This is from Nature magazine, Nature Medicine in 2020, and it shows the connection there with the ACE2 receptor. This is on the left side as you look at the screen, and the captions reference the SARS-CoV-2 virus, but remember, these are essentially the same virus. The COVID-19 virus is just a mutation of the SARS virus. So the progression is the same. But you see the spike binding with the ACE2 receptor, and then you see the cell engulfing the virus to use, and that's how the virus inserts itself for viral replication. This is in the initial phase, early phase of infection. And that's associated with the next picture over where you see early infection. This is the invasion and replication, and there may be symptoms, there may not. Remember, some patients go their whole course, never have symptoms, and then some people within a few days. Now, the pulmonary phase is when the virus, and you notice the blue triangle there, is showing that viral replication is increasing, and it kind of peaks there. That's at about somewhere between 1 to 14 days is the time frame, of course, varying a little bit from individual to individual. So this is the viral replication portion, as well as the body's viral response. So obviously, as the virus multiplies, the body's going to respond to it. But then that begins to fade off after, somewhere in the 1 to 14 day range. That replication part and viral response fades off. However, depending on the severity of the response, the treatment, the susceptibility of the individual, you can see that the inflammatory response can continue long after the viral response. The inflammatory response being that red triangle that doesn't look like a pyramid. It looks more like a ramp as it continues to escalate into the later phases. So in this pulmonary phase, this is where T cells begin to become damaged, where different phases of the inflammatory response begin to release inflammatory cytokines, which those cytokines are a lot of what produces the symptoms that we encounter, the achiness, the sore throat, the cough, all of those kind of effects of the immune response. And then as that worsens, as the inflammatory response worsens, as we move into a condition approximating cytokine storm, that's where shortness of breath and hypoxemia begin to develop. So now we have increasing severity here. Notice that the antiviral agents are listed there at the bottom that have demonstrated any kind of benefit. This is the optimal place to employ those. What I want to point out to you that is of the utmost importance is ivermectin is not in this list. Ivermectin does not treat COVID-19. It is an antimalarial or antiparasitic drug. It's great if you're a horse. It is not intended to be used in humans. It can be used in mediated doses, but not for the treatment of COVID-19. I can't be more explicit about that. If you see ivermectin on a test, question. It is not a choice unless the answer is what medicines do not work for the management of COVID-19. So I want to be very clear about that. The other piece here is this, the next phase, or this latter phase, is this hyperinflammatory phase. And notice that it is not necessarily associated with the highest volume of viral response. It's associated with the inflammatory response, these inflammatory mediators that are elicited in response to the virus. So they don't necessarily have to have a huge viral load to necessarily have a very severe illness. The inflammatory phase is where you get an implementation of other organ systems, such as the lungs, the heart, the kidneys, the vascularity itself. You may have heard of patients developing DIC, disseminated intravascular coagulopathy, brain issues, neurological delays, those sort of things that also get associated with long COVID. All of those components are a portion of this inflammatory latter phase, which is, in the anywhere between 10 days to weeks, possibly even month period, depending on how the patient is responding. This is where patients manifest with things like ARDS that we've alluded to earlier. Shock. The shock state could be septic shock. It could be cardiogenic shock, because we're moving into a place of multi-system organ failure. You notice the kidneys getting involved, the heart getting involved, lung, that's 3 organ systems. That's multi-system organ failure. So every organ system you add increases the mortality by a pretty dramatic number. So you also notice here that we add now immunomodulatory therapy and what we refer to as supportive care. So in this phase, what we're doing is using corticosteroids and other adjuncts to their care, the monoclonal antibodies, and also what may end up being ventilatory support, vasoactive drugs such as norepinephrine, phenylephrine, angiotensin II. These type of drugs would be things we're actually using to maintain a sustainable blood pressure to support the patient. We refer to that as supportive care to keep them from dying. And then you have, of course, the dysregulated immune response, which is when we get into a very protracted inflammatory manifestation of this illness. So this could be quite the complex infection. Now, what I have here is a schematic of the genome of the SARS-CoV-2. So that all of these genomes have been mapped. This is a reference that enabled me to actually find kind of this picture of the layout of the genome of the SARS-CoV-2. I don't expect you to know this. What I want you to understand from this, I want you to see how this is related to the vaccine. As I mentioned earlier, the influenza vaccine is an inactivated virus. So it has much of this genetic structure for the flu virus. It has its genetic structure, but it doesn't have its machinery that allows it to do the replicating within the cell. It allows the inflammatory response because it's got the shell of the virus. But this particular slide, what I want you to notice is the red box that I've created that overlays the spike portion of the DNA. So the SARS-COVID, COVID-19, the coronavirus has approximately 29,000 genes. That's the count across the top, where you see 1, 5K, 10K, 15K, 20, 25, and then 29K. Those are the genes that are a part of this genome. What I want you to notice is there's approximately 4,000 to 5,000 genes that are the only genes that are used from this DNA in the vaccine for the COVID-19 vaccine. What that means is the COVID-19 vaccine, as far as propagating COVID-19, giving someone COVID-19, making them sick from it, is far less likely even than the inactivated flu vaccine. You cannot get SARS or cannot get COVID-19 from the COVID-19 vaccine. You can't get it from the SARS. You can't get SARS from the COVID-19 vaccine. Anything you hear about that is just false, because there's not enough DNA from the virus to actually produce an illness associated with coronavirus. The DNA is not there. Also, it is important to understand that we are not inserting something into our DNA. What we're giving when we're giving the vaccine is we're giving this portion of the DNA of the virus that allows our messenger RNA, it doesn't insert it into it, it allows our messenger RNA to do its job and create the antibodies we need, because that's what it does in response to this spike. It creates antibodies from our own DNA, our own antibodies. It doesn't inject anything into DNA. So I share with you this so that you have correct information, because you will encounter people who say and propagate other things. So those are just the facts of this particular illness. This slide is another representation of the progression of COVID-19 and where the treatments fit. I just wanted to provide this to you so that you can see the incubation period, which this is for SARS, but so you would change this number up here to 14 days. And you can see this manifestation of the different phases from asymptomatic, mild, moderate, severe, and critical, and then what turns into long COVID in the convalescent process. So in these phases, what this slide shows you is where the medications that we have discussed fit in. And you'll notice that ivermectin is nowhere on this slide. So again, reiterating that those drugs are not used. These are just reflecting the drugs that are effective in the management of COVID-19, from the antiviral drugs to the monoclonal antibodies to supportive care. The drugs that mitigate the cytokine response, because the immune system just goes haywire in this overwhelmed state. So the clinical presentation incubation is anywhere from typically from 2 to 7 days, but can be up to 14 days before the manifestation of symptoms. So it can be a very long time before anybody shows up with having symptoms. And in fact, you may know people who had no symptoms at all. In fact, the first time I had COVID-19, I really had no symptoms. I had a headache, and that's not necessarily a symptom. And the only reason I knew it is because my wife tested positive. So I came home and actually tested and was positive. Would not have known it, never had known it if it hadn't been for Lisa testing. Majority of the patients, a slight majority, are male. And some of these, the statistics after this are in the initial phase shortly, in 2020, shortly after we had collected sufficient data on the outbreak. So this was actually published in the latter part of 2020, December, if I remember correctly. But in the early phases, majority of the population were at least 50 years or age or over, and the morbidity mortality was more than doubled if you were older than 50. So there was a high mortality associated with COVID-19 in the population over 50 years of age. Now, majority of the patients, so as you can see here, 60 to 90% had some pre-existing comorbidities. By comorbidities, I mean chronic conditions that can contribute to the shortening of life. And what I'd like to point out here is that the highest comorbidities were not associated with lung disease. Notice that pulmonary disease is down here toward the bottom. It's number 4. 4 to 10% of the patients had lung disease. So lung disease wasn't necessarily a profound comorbidity, but hypertension, because of the issues with hypertension and the angiotensin 1 angiotensin 2 cascade and their receptors, those patients with hypertension were the number one highest mortality comorbidity, and diabetes was right there behind it in the 17 to 34% range, and then other forms of cardiovascular disease aside from hypertension. So this would be heart disease and valvular disease and other things like that. So it was cardiovascular and diabetes that were the biggest and most lethal comorbidities associated with COVID-19. The key for management is early treatment, and early in the whole, as early as possible. Early on in 2020 and early 2021, our really biggest and most effective intervention was supportive care, high percentage oxygen with high PEEP, and convalescent plasma. So this is plasma that was donated by people who had COVID-19. Essentially what we're doing is we're giving them antibodies. They're not monoclonal antibodies because they weren't reproduced in a lab. They're antibodies that were produced in the lab that is the individual's body. So if you had COVID-19, you recovered, we would take a plasma donation from you, and plasma does not have to be cross-matched, and could be administered safely to someone else. So that was a pretty effective treatment early on. Remdesivir was the only antiviral that was approved in the treatment of, and still is, only antiviral approved in the treatment of, for the treatment of COVID-19. Earlier in the early studies on this drug, essentially what it demonstrated is it shortened the course of your illness. Either you got better faster or you died faster from this drug. It didn't necessarily make the outcomes a whole lot better, but it is something that does potentially help someone not die from this. The monoclonal antibodies, Regeneron, essentially the two different names there, were later developed once we could see that antibodies were the key and we could reproduce them in the lab. Then the monoclonal antibodies became effective in managing COVID-19 and help mitigating the severity of its illness. Not to mention the fact that vaccination was huge. When you start vaccinating people, then you are preempting the virus by creating at least some level of immunity in people, so they have the capacity at the beginning of the infection, actually before the infection, they have the capacity to begin to fight that viral invasion. So currently what we're doing is, again, Remdesivir is one approved for general treatment. The Paxlovid is newly emerging antiviral, but it has to be administered within the first 5 days of symptoms. So if you notice here, the nirmatrelvir blocks enzymatic activity, where the ritonavir boosts viral medication activity. So any antiviral medications we're giving, such as remdesivir, the ritonavir boosts its efficacy in assaulting. So we have combination treatments here that can help with fighting the infection. Then again, the monoclonal antibodies, currently some of the studies are paused because some patients have developed resistance, the virus has developed resistance. This is where, again, I mentioned earlier, you've got mutations that lead to strains. So some of the newer strains are resistant. They've developed a resistance to these particular antibodies. So we've kind of paused some research on that. Now there is still the bebtelovimab, which is the ACE2 blocker monoclonal antibody that prevents spike interaction, and that one still is being used. Now, these other medications are not necessarily antiviral related, but they help with the inflammatory process. So dexamethasone, hydrocortisone, those are steroid treatments Then you've got these other medications, the baricitinib and tofacitinib. They're J kinase inhibitors, which these are both of these and the two drugs below it basically are mitigating the inflammatory response, those inflammatory mediators. They're blunting that to help prevent the cytokine storm component that we were talking about earlier. And then the augmentation of using low molecular weight heparins, such as heparin and Lovenox, to help prevent the DIC component, which can then lend to, if you develop DIC, that can lead into multi-system organ failure and further complicate recovery. So that's currently where we're going. Again, notice ivermectin is not in this list. Ivermectin does not do anything for COVID-19, neither does hydroxychloroquine. That's just false information. Hydroxychloroquine, it was used early on. It was ineffective. It didn't do anything to help people get better because it's an anti-malarial drug. It's not an antiviral. So it's not going to work. It never did work. And the information that said both ivermectin and hydroxychloroquine worked was, in the interest of being blunt, it was a lie. So I can't emphasize that enough, and cannot underscore enough the importance of vaccination. This virus continues to mutate and evolve. So this is going to be an ongoing, continual vaccination process. It's not going to be a one and done per season. That's just the nature of this particular virus, because again, as we mentioned earlier, immunity does not sustain even with vaccination. These pictures are just here for you to get an image, an idea in your head of what ground glass opacities look like. The boxed in areas are CT images of portions of the lung that have ground glass opacities in them. So you can see, and this is a chest x-ray, you can see where on this chest x-ray, it just looks like somebody has taken a piece of glass with diamond and just kind of roughed it up. Again, to contrast from pulmonary edema, remember pulmonary edema, the infiltrates, this fluffy area in the lung, was coalesced around the vascular bed. And in this case, it's not. It's diffuse all over the lung fields. This is what makes this such a challenging pneumonia to treat when it evolves to that. Now, another highly infectious pneumonia, there aren't as many cases of this as there have been of COVID-19 currently in our culture, but we do have more cases than we would care to have out there, and we're very cautious about identifying cases and then also mitigating the spread. So with both COVID-19, less so with COVID-19 now because of vaccination and its endemic nature in our culture, tuberculosis is one of the key components for managing tuberculosis is contact tracing. So that's the first thing you should think of when a patient walks in and we are concerned they may have tuberculosis. One of the first questions should be, who have you been around? So tuberculosis is a mycobacterium tuberculosis that is very contagious and communicable. Now, not everyone who contracts the illness manifests with symptoms because the gone tubercle that forms can remain dormant for many, many, many years before manifesting in an infection. So someone could contract the illness, develop a gone tubercle in their lung, which generally shows up as a spot in one of the upper lobes. And so they have been infected, and yet it's been years since they ever had, or they may never have symptoms, or be years before they manifest with any symptoms. So it can be latent, and or another way to say that is dormant. And if it's dormant, latent, it's not contagious. However, if someone has it, you can contract it and be dormant. If you have contracted it and are dormant, you will still have a positive TB test, both a TB, ideally a positive TB skin test. There are cases where you have false negatives. Most institutions anymore rely on the quantiferin gold blood test to test for TB antibodies. It is an aerobic bacterium, which means it doesn't require oxygen to reproduce, and that upper lobe tubercle is distinctive on X-ray. So that can be a very diagnostic finding. It is spread by airborne droplet transmission. This is why we had an N95 masks out there to begin with. These patients have to be in a reverse airflow room, which means the air is not flowing out of that room. Air is flowing into the room. So there is a direct flow that takes the air that's in the room into the filtration system, into the HEPA filtration system, to remove the TB microbacterium from the air. That's the reason for the reverse flow. In other rooms, the air flows out of the room into the hallways. In this case, we don't want to be pushing that air out into the hallways. We want to be taking it directly to the filtration system in the ductwork. The confirmation of diagnosis is done by acid fast and or quantiferin gold testing. Acid fast is a sputum specimen that's done, and the Mycobacterium tuberculosis is fixed on slide by an acid solution. That's what's meant by acid fast. Quantiferin gold tests for the presence of antibodies to Mycobacterium tuberculosis. So, as I mentioned before, patient may not exhibit symptoms until this illness is advanced, and in some cases it lays dormant for many years. Characteristic symptoms. So you can imagine all of the other pneumonia symptoms: shortness of breath, diaphoresis, etc. All of those things associated with pneumonia can happen with tuberculosis pneumonia. What's unique, that is characteristically unique of TB, is hemoptysis, or coughing up blood, and night sweats. So those two things are unique. Those are the kind of things that show up as distinctive diagnostic findings on intake or report from the patient. So those would be a couple things you'd really want to lock down related to tuberculosis because they stand out. The first line treatment for tuberculosis is going to be rifampin and isoniazid. This is going to be a 6 to 12 week course of treatment. And that is mostly due to evolving drug resistance to these drugs. These drugs have been around for a while. So as TB lives, as different microbacterium and infectious agents live, they talk to one another and breed with one another and develop resistance. So primary resistance is resistance to first line agents, and then secondary resistance is to one or more. So if a patient were to develop resistance to TB that's refractory to rifampin, that would be an example of first-line resistance. But if it were to develop resistance to both rifampin and isoniazid, then that would be considered secondary drug resistance. And then once you develop resistance to both of those drugs and treatment, then we're in a multi-drug resistant, MDR, you see that abbreviation, multi-drug resistant organism. So we're going to isolate these patients for 2 to 3 weeks during therapy, and then continue the therapy for another 3 to 9 weeks after that. As far as management this goes, we're going to manage this the same way we do other pneumonias. The patients may require intubation depending on how severe they become. They require oxygen therapy. They may need mucolytics. They may need other augments, and other treatments depending on what concurrent conditions they have. Medication compliance is huge with this because the regimen is very strict and long. So compliance is a huge issue here. You have to take the medications as prescribed for the full course, not just when you're feeling better or don't have any symptoms or think it's all okay. Liver function, both rifampin and isoniazid can compromise liver function. So consuming things like alcohol is something that's got to be limited, if not eliminated, during a patient's TB treatment course. And you can imagine from what you know of already in our culture, the prevalence of the use of alcohol, how big of a challenge that could be getting people to stop for 6 weeks to 12 weeks. Obviously, we want to isolate as much as possible and prevent transmission to other individuals in the family or in the community. And then testing people who may have been around this individual or who work in healthcare environments, such as ourselves, people who work in long-term care facilities. So we need to monitor for the exposure to TB so that if it begins to manifest, we don't end up with some kind of epidemic type outbreak. This little slide right here gives you an idea of the way the skin test is interpreted. There are still places who are doing skin testing, and this gives you some guidelines about what is considered negative. And then this 5 millimeter or more range can be significant, but there can also be some cross sensitivity with patients who are HIV positive. So we have to do a little more asking if we see a positive test in this 5 to 10 millimeter range. And then obviously 10 millimeter or more, then we're definitely looking deeply into that. So we'll stop here with pneumonia, and then in the next section, we will pick up on the neoplasms and cancer types related to lung.